learning more about that are in some of our healthcare professional in the healthcare space here in the area, and especially in the section with food justice, because that's like a lot of the work that we do as well in our different chapters. My midnight snack has been really patacones and plantains and like all the different plantains that Trader Joe sell. I am buying the different versions of them. So I am, that's been like one of the things that I've been kind of going for recently. And then exciting work on our end is that we have been officially, last year of my work has been really talking with different stakeholders in this food system, since we're going to be based out of Chicago. So growers and eaters and buyers, and we're excited that we've been approved by our board of directors. And so we're officially launching, and we're going to be able to start aggregating and distributing and partnering with more folks in the community to connect good regionally sourced food. So I'm excited to be part of that. And yeah, if there's any questions or interested in connecting, I can drop my email in the chat.
Thanks, Eliana. Any one other person want to introduce perhaps, and then we'll move on to the next part of our agenda.
Hi everyone, I could go. I'm AK, the Swedish Hospital. Midnight snack, I'd probably second cheese or Cheez-Its. I have Cheez-Its in my car and in my house, everywhere. And probably our newest thing that I submitted an IRB for yesterday, so hopefully it will be approved and we can start work, but we're doing a food prescription program with the Geary Clinic residents in partnership with the Friendship Center. So it'll be for pre-diabetic folks who are experiencing food insecurity. The goal is we're going to work to remove all of as many barriers as we can for food. We're providing kitchen supplies, we're providing a wheelie bag, transportation vouchers, and then getting them connected to the Friendship Center, where we're going to, on the back end, do some shelf labeling for nutrition nudges, I'll be leading grocery store tours there. We'll get them into our prep shop cook class, which teaches folks how to prep shop and cook. And then they'll have their 3-month follow-up visit with their PCP, and we're going to do some biometric analysis of BMI, A1C, and blood pressure, doing surveys on diabetes knowledge and purchasing behavior, and then food frequency questionnaires pre and post. So that should be starting recruitment, I think, in February is our goal, and it'll run till June. So pretty excited.
Thanks so much for sharing that, AK. That's great. And agree with Joanna's comment about all of the amazing and beautiful things. So thanks for sharing all of that this morning. I will let Rashida introduce herself real quick, and then I think you'll probably pass it over to Lucy for the overview, right, Rashida? And I'll put my screen back up.
Yes, thanks so much, Jess. Good morning, everyone. My name is Rashida Balogan. I'm a program manager here with the Alliance for Health Equity in IPHI. I've seen you in these meetings, but just in a different role. So I'm happy to see everyone here, and Happy New Year. And I'm also excited to announce that Lucy is here today, and she is back with us as a contractor for IPHI. So we are excited. I know quite a few people were bummed when they found out that she was no longer with us, but we got her back. I'm gonna let Lucy say hi, and then she's gonna go ahead and go over, just refresh our visions and purpose statements. Go ahead, Lucy.
Thanks, Rashida. Jess gave me an opportunity to say hello earlier, so thanks to those who are just joining as well. And I'll get us started with the slides as Jess is pulling them back up. I think most of the folks in this group are pretty familiar with our shared definition, vision, and values, which we came up with last year, but continue to evolve. So I will run through those with everyone. And just as a reminder, if you have any feedback you'd like to provide us on this shared definition, vision, and values for our group, you are always welcome to share that feedback with us via email. All righty, thanks, Jess. So since we are in a new year, I'll go ahead and read our full definition that we've set out for ourselves. As a reminder, this is a pretty robust definition, and it is our goal in the next month or two to put together a strong one-liner that everyone in this group can share out with your networks, something that's a little bit more succinct than what you see here, and that is definitely in the works, but I'll read our full definition today so that we can all get grounded. So our group looks at food as medicine, healing, and justice. Our future is one where food is a human right, where insurance dollars can be used to invest in programs that provide nourishing food, where there is no longer reliance on the charitable food system, where there are resources to procure nourishing food that exist for everyone, where food can be grown locally and sustainably by anyone who wants to grow it, and where communities are celebrated for their cultural food practices and traditions. In this utopia, individuals, communities, and community-based organizations, hospitals and healthcare systems, insurers, industry partners, and government partners collaborate to advance healing and justice through shared food as medicine programs. And we can go to the next slide, Jess. And so last year, we wanted to find a visual way of sharing our values for this group. And so within this image, you'll see the plants, which represent our different food as medicine programs. These can be all different types of programs that fall into the food as medicine ecosystem. So things like referrals for SNAP and WIC, produce prescription programs, prepared meal or medically tailored meal programs, voucher programs, cooking classes. This is not the only 5 programs that we are looking at. These are just some examples of the programs that we consider to be part of food as medicine. So these are our plants, and our plants need to take root in healthy soil. And the soil, within the soil, we find the things that nourish our programs. So things like being environmentally sustainable, creating shared economies, being invested in food sovereignty, anti-colonialism, anti-ableism, creating programs that are transparent and really focusing on nourishing, really nourishing the people that we support, nourishing the communities we support, nourishing one another and ourselves. And then also in this graphic, you'll see, of course, our sunlight, and the sunlight is what gives our programs energy to grow. So our guiding principle, or our sun, is racial and social justice and community-driven solutions. And then the rain, or the water, is what sustains our programs. So within that, we think of things like abundant funding and equitable land and water access. These are really the things that we absolutely need to help our programs grow and flourish. And so we can go to the next slide, Jess. And so as a reminder, the food as medicine work that we're doing fits into the Alliance for Health Equity's broader food action agenda, which is here. This agenda can be found on our website. A lot of these goals align with some of the priorities we've set for ourselves within this subcommittee. And we can go to the next slide, Jess. And then this is just a reminder of where the Food as Medicine Subcommittee sits within the work that the Alliance for Health Equity is doing with our partners. So we have a food leadership team, which consists of a lot of folks on this call who help kind of steer our broader food access and nutrition security work group. Within that work group, we've developed the food action agenda, which you just saw on the last slide, and we co-organize 2 subcommittees, or 2 smaller teams. One, of course, is our Food as Medicine Subcommittee, which is co-convened with Dr. Surya Lofton. And then the other is a Good Food Purchasing and Healthcare Learning Cohort, which is co-convened by SIFPAC and the doula part. If you have any questions about these other groups or would like to learn more, you're welcome to shoot us an email. And then you'll see on the right-hand side, we also make sure to align ourselves with the work of other regional collaboratives and coalitions. This list is not exhaustive, but we've tried to highlight many of our amazing partners who help us do better in our collective work. And so with that, I am going to pass it back to Rashida, who's going to take us into an overview of our key informant interviews.
Thank you, Lucy. Hi, everyone again. I am excited to bring this portion of the meeting to you. So at the end of last year, the last quarter of last year, we embarked on a new endeavor to interview key informants to get information regarding food reimbursements. And so the purpose of that, it aligned with our 2023 priorities and which are centered on marketing and telling the story of food and medicine, strengthening the case for reimbursement by insurance providers, and improving evaluation of food medicine programs. So in accordance with those priorities, we began conducting key informant interviews last year. And through those interviews with our local and national partners, we have who had expertise in reimbursement, coding, and insurance policy. We hope to identify best practices and opportunities that we may leverage in Illinois to advocate for the expansion of reimbursement for food intervention in healthcare setting. So thus far, what we've done is we've conducted 6 interviews. Our informants were happy to share freely with us. We did make a commitment to de-identify any information that we would present and only present in an aggregate, which is why we're going to give you today a brief summary of the information. And then later on, Dr. Saria Lofton has graciously agreed to help us with the data analysis of the interviews that we will be able to share later. In the meantime, the Alliance has compiled some key takeaways that I would like to share with you right now. So one of the main themes were some programs that we should be watching. There are pilot programs and studies across the United States that do already address the food as medicine and reimbursement, food access and security. Some are pre-pandemic and others have just launched since. And we should anticipate that there will be many more pilots as a result of the White House Conference on Hunger and Nutrition and Health that recently took place this summer. Food is Medicine Massachusetts is one of the pilot programs that was launched prior to the pandemic, and it provides valuable insight. They provide valuable insight on their website, regarding their food and health pilot. In addition to their Food is Medicine estate plan, we will provide those links for you so that you will have the opportunity to go in and research some of those as well. California also launched their Food is Medicine project prior to the pandemic. And most recently, since the pandemic, they have launched a 12-week medically tailored meals program for beneficiaries with congestive heart failure. And then finally, most notably in North Carolina, the Healthy Opportunities Pilot, the North Carolina Department of Health and Human Services is a pilot that we should be following closely. While the pilot covers all social determinants of health, which are things that we're greatly interested in, Food is Medicine program is an integral part of this program. The food services benefit of this pilot became first available most recently in March of 2022. And the aim of this program, after rigorous evaluation, is to provide evidence-based food proof of food is medicine to be effective in improving health outcomes and reducing healthcare costs. The most significant part about this program is that the North Carolina Medicaid and Managed Care has stated that based upon the findings of this particular pilot, if there is evidence-based that food and medicine is effective in improving health outcomes and reducing costs, that they will begin to implement it statewide integration across North Carolina. They have already begun to report back some of their successes on the website. Again, along with the recordings, I see Lucy is dropping some links in the chat for me. Thank you, Lucy. In addition to the programs that we're watching, some other things specifically are the evaluation, how these programs are evaluated, which was a key component of the criteria for this North Carolina pilot. So we should be watching these current programs closely in addition to how they're being evaluated. As one of our informants stated, these programs need to be shown to be effective in improving health outcomes and reducing healthcare costs, which is essentially what North Carolina based their actions upon. So in the realm of policy and legislation, we have the HR 5370 Medically Tailored Home Delivered Meal Compensation Pilot Act of 2021. So this bill will begin to open up benefits to this vulnerable population by directing the Secretary of Health and Human Services to conduct a demonstration pilot program to test the provision of medically tailored meals to recently hospitalized Medicare enrollees with conditions such as congestive heart failure, diabetes, COPD, and kidney disease, all of the chronic diseases that our partners are used to seeing. This bill currently has more than 50 sponsors. Another key takeaway that was a key theme that we heard from quite a few of our informants was that amending the Illinois 1115 waiver is an important opportunity, because basically what they were saying was the majority of what happens in Illinois is a result of the amended waivers. So for example, in addition to amendments for the 1115 waiver, the HCBS Home of Community-Based Services waiver can be amended to include food reimbursements. So it is not always necessary to reinvent the wheel. Various amendments to the waiver could actually benefit some of the programs that we are advocating for. So ideas for next steps, there were quite a few, and this is actually going to be a part of our breakout session. So some of the suggested actions that we ought to consider taking and recommendations from the informants were to develop a strategy to partner with Medicaid, managed care organizations, and other partners to gain more in-depth understanding of the Z codes and coding processes. So one of the things that we did not get a significant amount of information from was that coding process. It seems to be quite elusive to most everyone except the people that actually work in its spheres. So that was the suggestion for us in order to be able to get more information on it, because I know a lot of our partners are very much interested in that portion of the reimbursement. They also encouraged us to think about sustainability and approach for program evaluation, which we mentioned earlier, to measure the equity impact and benefits of food as medicine programs. So, and in addition to working across sectors, to come up with different initiatives to partner with outside of medical centers. So basically to think outside of the box, maybe partnerships with CBOs to get an understanding of how they are working with the Centers for Medicare and Medicaid using the Z codes. And then learning from programs like VeggieRx and Ryan White that have successfully brought together funding across sectors. In addition to leveraging policy and program opportunities for pilots, including the 1115 waiver, healthcare transformation collaboratives, and programs or funding that may result from the 2022 White House Summit. So as you know, the White House, in addition to the summit, they are also launching their own research and hoping to get findings for that and eventually subsequently more funding. So what we would like to do today is to break out into breakout groups. I'm not really sure how many people we have on today. Let's see. Maybe 2 to 3 breakout. Okay, about 3 breakout groups to discuss these findings, as well as to go over some of the ideas for next steps, and then also to hear what your opinions and views are of some of the next steps that we might take. So I am going to.
Rashida, before we go into breakouts, I had one item that I wanted to highlight that we can't really put in writing on the slide, but
Sure.
wanted to just check if anyone else had any questions or insights that you wanted to share about these next steps. I saw the discussion in the chat, in particular, Lindsay's question about whether children are eligible for some of these existing pilots. And as Lucy had responded, what we heard in particular from North Carolina is that it is focused on adults currently, but they were really trying to think about how to design some of the food interventions to benefit the whole household, even if one member of the household was sort of the qualifying person. But just curious if others know of any other programs or pilots that have specifically focused on children that we should look into, or any other thoughts that folks have. Go ahead, Lindsay.
Hi, everyone. Thanks, Jess. Wait, let me lower my hand. I just wanted to say, so we've been having some meetings around this topic at the hospital also. And the obvious one, legislatively being the 1115 waivers. But our government relations people told me, at least, that, you know, that's a relatively big lift to ask for that to try to get that passed for the state of Illinois, even though we know what's going on in some of the pilots that you just referenced. She said there's 2 other potential avenues, which would be less of a heavy lift than a waiver, which would be a state plan amendment. So potentially there's an opportunity to amend. I don't exactly know what that means or what that looks like, but that would be the simplest approach. And then the other is, you know, the Z codes that, you know, they're not quote unquote turned on for reimbursement, but there could be advocacy around getting insurers to basically, or Medicaid, CMS to turn to, you know, allow those codes to be used for reimbursement because they exist. We all know that the 55 to 65 are the, you know, 10 range of Z codes that exist for food insecurity, but they're not quote unquote turned on for reimbursement at the moment. So one of the things that we could think about is how do we get advocacy around the mechanisms exist. We just need to have advocacy around getting paid for usage of those mechanisms.
Lindsay, I'm glad you mentioned the state plan amendment. Actually, in one of the information that we have in the slide for the state of California, that is one of the things that they did. They amended a state plan to include food as medicine and reimbursement. So that is definitely something that we can look into. Thank you.
Yeah, thanks for that clarification. It's good to know that it's been done somewhere successfully.
Thanks, Lindsay. I also wanted to, so 2 sort of additional points to what you just raised. So particularly around the 1115 waiver, as some folks who work in healthcare on this call may be aware, and that's a waiver that the state Medicaid agency requests from the federal government to be able to use Medicaid dollars in some more innovative ways than normally would. So Illinois, back under the Rauner administration, did submit and receive an 1115 waiver that has nothing to do with food, but is an existing policy vehicle in the state, and it is set to expire this year. There are folks on this call who may know more, and I know that the state Medicaid has not made any public announcements about any of this yet, but what we do know is that the federal government has advised the state that it makes sense to try to amend that waiver before it expires, rather than A, letting it expire, or B, trying to create a new 1115 waiver. So even if the topics that the state wants to, or the types of services that the state wants to test out and pilot through an 1115 have nothing to do with the types of services that were in the original one, the advisement that they've received is to work on amending the existing 1115. So I don't know a lot of details about timeline, but our understanding is that there is going to be a process for amending that waiver. What the state exactly intends to include there in terms of the realm of social needs services is a little bit up in the air, but we do understand that the 1115 waiver is going to be amended this year, and it may happen earlier in the year than we all expect. So I think as one follow-up to this call, it may make sense for a few folks who are really more intimately involved with government relations at the state level to potentially have a follow-up call to sort of think through strategy of whether it makes sense to include any advocacy around food, knowing that this waiver may happen in the first or second quarter of this year. Anyone else on the call have anything else to add about that? I just want to make sure that everyone has at least some context around the 1115 waiver. Any questions on that? I'm by no means an expert, but I do know that it's something that will be amended this year based on what we're hearing from different folks. And then the other piece I wanted to also mention related to the Z codes and what Lindsay said about you know, how those could be turned on for reimbursement. I I do also think that my understanding is that some of the contracts for Medicaid managed care organizations, MCOs, are going to be renegotiated. I don't know if anyone on the call knows more about that. That's something I actually don't have any details about, but that would be something else we'll want to keep in mind as a policy opportunity if in fact there will be renegotiation of some contracts with MCOs, then that may be a moment to be able to pilot some more, use of Z codes with particular populations potentially. Any other comments or questions about the key actions that Rashida highlighted here? Okay, I'll pass it back over to you then, Rashida.
Okay, everyone, it's time for breakouts. We've picked 3 rooms, so we'll have 6 to 7 participants in a room. And I'll also go ahead and post those questions in the chat so you'll have them at top of mind. See you back here in, I think we have like 12 minutes, maybe. Is that right, Jess? Something like that. So you should be able to, there we go, start joining rooms. Let me grab those questions or suggestions, I should say, for next step. Do we have everyone in the room?
It looks like it, except you and me.
Okay.
Oh my goodness, what a morning, Rashida.
Jess, I'm dying. Like I don't drink in the daytime, but I feel like I should drink.
I'm not sure if, did you put the questions in the chat? Because I don't see it in mine.
I'm copying them.
Okay.
Yeah. Like, what in the world? I need to see Christina before I go back home. Yeah. See, it's not pasting. Is it? Oh, see, it's the weirdest thing. Like I'm trying to paste, it won't paste.
Okay, let me try to copy those.
I should have stopped by to see her yesterday when my Outlook app does not work. It has this big yellow triangle with an exclamation point in it. And slowly but surely everything else just stopped working. Okay, I'm gonna join, let me see, a room that, okay, Dr. Lofton.
Maybe room 3.
3.
Or room 1, 1 or 3. And then I can go to the other one. Which one do you want to go to?
I'll go to 3.
Okay, I'll go to
Okay.
1.
All right. Yeah, I want to let me go. Yes. Are we still just here? I can't hear anything right now. Oh, you're muted. You can't go. Okay, room 1. Join. Yes.
I took notes of all different farms. Oh my gosh, my memory is starting to leave me. It comes back in like pieces, but we did meet. It was the meeting before last, or was it last meeting?
we met at Food Tank. We had a conversation. Everybody had still like between like wearing masks and not wearing masks. I'm wearing different glasses.
Yeah. Oh, yeah. You remember me from that. You're good. Cause that was what, early in August, September?
I think sometime around there, or fall. But so it's like two questions, right? One is about like evaluation, and the other one is like,
Yeah, what do you think about the evaluation? And then also the other one, what would be like suggestions for next steps? So I'm gonna be quiet and I'm gonna let folks talk and I'm gonna take notes.
Sorry, I have it from the slide. So it's strategically partnering with Medicaid, managed care organizations, and other partners to gain a more in-depth understanding of Z codes and the coding process. That's one. And then two is sustainability and approach for program evaluation to measure equity, impact, and benefits of food as medicine programs.
I think I'm super curious about the sustainability and approach. And I only say that because we as an organization, the Con Market, we are working on a project in our southeast part chapter, and that is focused on this food as medicine component. And we got funded recently to do this work, and we're partnering with another local organization that is the one that is in charge of essentially the facilitator with the prescribing beneficiaries, with the beneficiaries of these prescription boxes. And so some of the questions that came up during a recent conversation we had with them was like, how do you make this sustainable over time? And in a sense that like it was pretty like direct in the sense of like, because this can be something that is going to rely on philanthropy or in a degree of funding of some sort, like how do you create I don't know if marketplace is the right way, but like the building the case for it. And I think the answer came back to this like evaluation and being able to, the ability of some of these programs to track like a year after being part of this, like what has changed in which ways, and in a way that like, you know, the problem that you have with organizations like us is like, we're not going to get an IRB to be able to like get a sense of what the health outcomes are. We're just going to be like, we gave this many boxes, right? And so that's the extent of it. And like, you can see like what the populations that were affected and how that improved their access to food. But I think like where it becomes interesting is like, okay, what is the impact to actual health? Because that's the intended purpose. And like, that's where things kind of like, at least it seems to be like a big missing piece of this. And I only know of one other organization here that's doing something to address it. And I haven't checked in with them, but like with the community health program from Rush, I know that they are doing the school-based interventions, and they have 3 different schools, and they're working with top box, and they have them in a box description, and they, you know, they're looking at following up with a lot of these participants at 3 months, at 6 months, at 1 year. So like, I think that that's something to borrow or like understand how that's progressing and how that's gone, because I think like that's one part that, well, I can be somebody that like helps facilitate everybody that from the communities that need it to like the growers that are from an equity perspective, because we're working with this cohort of Black farmers in Georgia. Like, how do we like get a more transcendent answer also, not only from our program perspective, but I think that it's something that it's general kind of barrier in most food as medicine programs. So that I'm curious to like hear what people have learned in that sense of, you know, like the evaluation piece.
I found that with food as medicine programs, like what I run, following up with people, I mean, ultimately what we want to achieve is behavior change over time and improved health outcomes. And so you definitely need some research savvy people, data scientists involved. I have also found that to get good metrics after the interventions, after our, cooking classes, that we're going to have to start incentivizing those. I recently sent out an exit survey to around the 60 people that we taught 6-week cooking classes to last year, and I got 4 back. And that was asking them to do it for free. So I'm wondering if incentivizing it is going to help with those metrics. And this was following up to find out, has your behavior changed over time? Do you feel healthier? And then to get more sciencey about it, which might be interesting to you, Eliana, is that I'm involved in a study that we'll be implementing in my 6-week cooking classes with University of Chicago digestive diseases section with Dr. Edwin McDonald, and we're actually tracking the microbiome of our participants of a certain cohort. So we will be collecting blood and stool weekly, I believe, throughout the cooking classes, and finding out if, and I already have a written curriculum, and we might also be working with their metabolic clinic patients. So the weight management, people that are trying to get a handle on their weight. So we'll actually be tracking blood and stool. Of course, not me personally, but we have it fully funded to do the home kits. And then those will go straight to the lab. And then we'll find out not only through their mouths what they're telling us about, was this effective to you mentally, physically, also spiritually, because we do create a community of support, and not spiritually in the religious sense, but the feelings of fellowship. And then we're actually going to find out what their bodies say. So this is super exciting. It's in the work. We did have the, white paper, IRB. It's all systems go. We just have to choose what cohort we're doing it in. Yeah, but it's not based on boxes, although we could. We're also prepared to do medically tailored meals at any time. Now, I partner with Farm on Ogden in North Lawndale, and I teach there with their dietitian. We do the 6-week cooking classes together, and those are all Veggie RX participants. I get the beauty of they recruit everyone for me. I just show up and teach. And they get the beauty of in-house interventions with their clients who have been prescribed. And we do those cohorts. We did 2 last year. I did 1 in English and 1 in Spanish. And we're going to start those again in March. So what's happening here, I don't understand the question very well, because I don't know about Medicaid. I don't know about a Z code. I don't know. But as a boots on the ground person, trying to get info and trying to help people feel good about themselves, that's I don't know if I kind of info dumped, which is my jam, to see if there's anything in there that resonates. I kind of felt like what you were saying, Eliana, was like, I felt like what I'm doing is kind of what you're wanting.
Yeah, exactly. And I think to the link that I can think, and I hope that somebody that definitely, like you said, you need more seasoned in this Medicare and C-codes world. One thing that I learned recently from the people that this Healthy Opportunities pilot in North Carolina, I know a couple of folks that are involved. One that it's a hub that's very similar to what I do, and the other one that they do medically prepared meals. And so they signed up themselves to be a Medicare provider. And so I think that maybe it's like the transcending point that I thought it was interesting, where it's like a food production meal prep organization is becoming a certified to be like a Medicare.
Yeah, and they do that in Philadelphia too. And we're also doing something at UIC where we'll be working with Black women with hypertension and obesity and breast cancer survivors. So we'll be tracking with blood and all these metrics, and we'll be able to share that out. But I think that in Philadelphia, they have a more they're more have a more of an interest in these things, and so they've created it within their legislature. That's what we need to be able to get to what you're talking about, Leon.
Yeah,
because I think that's part of that, to have that as Medicaid.
And I think that's the barrier in some ways of how do you get people to buy more of these things and getting reimbursed through their government funded medical programs. And I think So this organization, they became a priority, so like they actually could be referred by the
Right.
doctor to get
Right.
like a specific tailored meals if you have like diabetes or any other chronic illness. So
Welcome back, everyone. Those breakout sessions are never long enough, are they? Next, we would like to, before we close up, want to be mindful of everyone's time. We would like to hear a few words from Dr. Surreal Lofton. Whatever your thoughts are on the breakout, and then some closing remarks.
Sure. No, I think we are starting some really good conversations around what we're looking for from, General Assembly when we're looking out with government relations. And I think, as you alluded to earlier, we'll have to have some more, maybe a smaller group conversation around that. But then looking at evaluation of as it pertains to biomarkers, because looking at like cancer risk reduction, all these diet-related diseases, and we look at cardiometabolic health, cardiovascular hypertension, things that are impacting health disparities and how diet exacerbates that. So how we're able to track those metrics throughout, and I think there's a lot of people in this group that are interested in that around, as it, from childhood to adulthood, and even beyond to like middle adult, and then older adults, and how we could see what some of the differences of what this work could be. And then whatever anyone else may have to say, that was what was in our group, but it might be some other things that were said in the other groups as well.
Was there anyone else who wanted to share some things from their group?
Sure, this is Jennifer, Chicago Department of Public Health. We thought that Jess's mentioning and Lindsay's mentioning of the Z codes and the whole MCO contract angle is something that is definitely worth pursuing. Talking to the right people to find out what the next steps are in that area. And then also hopefully engaging Mary Elsner and ICAP, once this goes down the line of hopefully being added, and doctors need to be informed that Mary's group would be able to assist with some of the education component. I believe in connection with their Food is Medicine grant that they're working on, this might align nicely with that as well. Thanks.
Thank you,
So
Jennifer.
sorry to volunteer you, Mary.
Anyone else have any last remarks?
Our pediatricians are on today, so I'm sure they took that into account in terms of talking about the education that we're rolling out. Although we don't know if it would, be put into practice yet. So thank you, Jennifer.
Thanks. Jess, would you be able to put up the final slides?
Yes, pulling them up now.
Thank you. So just some wrap-up items and next steps. We talked about what can we do to prepare for the next time we meet, and how does everyone want to be involved? We'd love to hear from you. You can email us. You'll see our emails on the final slide. Reach out to us. We do appreciate your emails and we do read them. I get quite a few from Lindsay. I appreciate those very much. Our next meeting date, let's see, the food work group meeting is next. It's in February. Is that correct? Let me see. Yes, sorry. So the next food work group meeting is Thursday, February 23rd. And then our next subcommittee meeting will be in April 12th. I want to thank everyone for coming. Jess, did you have any final remarks, or Lucy?
Thanks, everyone, and we'll be following up as Dr. Lofton said, with the smaller group that has previously volunteered around reimbursement policy to discuss some of the more time-sensitive upcoming opportunities. So appreciate everybody's time today, and thanks, Dr. Lofton, for convening this group.
Thank you.
Thanks, everybody.
Thank you.
Thanks, Dr. Lofton. Nice to meet you.
Thank you.